Our next talk is going to be from Dr. Stephen Grinspoon. We mentioned earlier today, he was on the panel talking about, some endocrinologic manifestations. He's our honorary HIV provider because he's been working in the HIV field of cardiovascular disease for so long. And he's going to be talking with us today about reducing cardiovascular risk in people with HIV, especially in light of the continuing results that are being produced by the REPRIEVE study. Dr. Grinspoon.
Thank you very much. It's really a pleasure to be able to speak with you guys today, and I look forward to your questions after the presentation. These are my conflicts and relationships. And here are the learning objectives. I'm going to be describing the rates of cardiovascular disease among people with HIV and the key risk factors contributing. And I'll be describing the rationale for the REPRIEVE trial, our primary findings, and their impact on the care of people with HIV globally. And I'll be telling you about some guidelines changes that just occurred, which are very important for your practice. And I'll also be describing the unique phenotype of cardiovascular disease in people with HIV and novel mechanisms, and then morph into the effects on plaque in the coronary arteries, which is a subsequent finding to our main findings. These secondary findings were just published last month. So myocardial infarction is a big deal in people with HIV. We've known this for a long time, which is why we did REPRIEVE, but here are some recent data from NA Accord showing myocardial infarction rates increasing, and then looking at subgroups increasing among many, many subgroups, almost all the subgroups of people with HIV, and particularly in certain subgroups. And there's racial effects and effects by how HIV was obtained. So I'm not going to have you answer these because I realize that they were part of the pre-test questionnaire, but I think they're important to go over. What's the main, this is sort of to understand your knowledge, and I can tell you that 87% got this one right, so that's good. What is the main cause of cardiovascular disease in people with HIV? And the answer was the last one, D, which was appreciated by the vast majority of you. The second question I have is much harder, and it's caused by a combination of traditional and non-traditional risks, including inflammatory and immune-mediated mechanisms, which is so interesting. As I mentioned before, having a detectable viral load is one of the main risk factors for cardiovascular disease in HIV. Not what your LDL is, which is really interesting, and I'm going to go over that. Cardiovascular disease in people with HIV is almost exclusively caused by antiretroviral therapies, which can cause metabolic abnormalities. Yes, they can cause metabolic abnormalities, weight with integrase, insulin resistance, different things, but this is not the primary cause of cardiovascular disease. It's not the ART, it's actually the virus. Cardiovascular disease in people with HIV is caused by increased age of people with HIV, a population in which one would expect increased cardiovascular disease. No, because people with HIV often get cardiovascular disease at a young age, which is very important. Not to say that you're not at increased risk at an older age, but make sure you remember that it occurs in young age. Cardiovascular disease in people with HIV is caused by higher prevalence of behavioral risk factors such as smoking and elevated BMI. Well, yes, those do contribute, but they're not the main contributing factors in this. So they're important things to modify, but I would say that the D is more correct than C, although C is partially correct. Oh, so I went through that already. So what are the current challenges in preventing cardiovascular disease in people with HIV? Identifying patients with subclinical disease is very important. The current risk identification strategies are not adequate, which is a really important point. You can't know by using our typical AHA prediction algorithms who's going to have cardiovascular disease. I have a slide on this that is taken from our REPRIEVE study. We need to develop an intervention that addresses both traditional and immune-related risk factors, i.e. if you reduce inflammation too much, you can actually increase the risk of infections. And the canakinumab story, anti-IL-6 and other strategies have told us that if you if you have an intervention that has too much of an effect on inflammation, you can actually get opportunistic infections. Particularly, we saw that with interleukin-1 beta antagonists and canakinumab. So we have to thread the needle and do it just right. We want to target inflammation and traditional risk, but we don't want to overtreat inflammation, because that's an important mechanism by which we keep the virus, this innate immune activation actually keeps opportunistic infections in check. So really a tight balance here. And we want to, of course, develop a strategy that is safe and effective. So why did we do REPRIEVE? Well, we hypothesized that a statin strategy, and I'll go through why statin in a moment, that a statin strategy would prevent cardiovascular disease, even in people with HIV with low to moderate traditional risk, and would have pleiotropic effects beyond LDL lowering that would address the unique phenotype of inflamed, low attenuation, vulnerable plaque, which we have defined over the years. And on the pictures on the right, you can see that, and I might let you know that plaque that's hard and calcified, although you think of a calcium score as associated with the risk, in fact, it's the non-calcified plaque that's eccentric that is so vulnerable for rupture. And that's the type of plaque, unfortunately, that people with HIV have. In the lower panel, we've done studies using FDG PET imaging showing this incredible inflammation at the arterial surface among people with HIV with the same risk factor score as non-HIV infected patients. So they're inflamed, they have atypical plaque, and we thought that this would be an interesting population to assess this hypothesis. And the design of REPRIEVE is really unique in that most of the prior prevention trials, in fact, all of the prior prevention trials in the history of medicine, okay, have focused on population with a higher baseline traditional risk than REPRIEVE. REPRIEVE pushed the limit in terms, and I'll tell you why in a minute, of who we are targeting for prevention. The median ASCVD risk in people with HIV in REPRIEVE was 4.6%. And before we came up with REPRIEVE, I would venture to say that most of you would just kind of passed over that kind of patient for cardiovascular disease risk protection. And you can see now that that's not the case anymore, and guidelines have changed around that, which I'm going to focus on in the subsequent part of this talk. If you look at all the other trials like Jupiter and all the other big prevention trials, the median baseline risk was like 10%. Much, much higher than. So we were nervous about REPRIEVE, that would it work in a population with such low predicted risk. So talk about anxiety. That was my anxiety in designing REPRIEVE. Why do we pick statins? Statins are really unique. They do lower LDL, that's for sure. And most people ascribe their efficacy based on LDL lowering. That is, if you took a quiz, that's what you would put down. They lower LDL. But that really may only be part of the story. And in fact, it may not even be the most important part of the story. They reduce lipid oxidation in atheromas, and they also reduce NLRP3 inflammasome activation and potentially plaque inflammation. You can see this cartoon on the left by reducing mid-activity. They perform this and they reduce the NLRP3 inflammasome. And when you look at circulating factors, you can see effects on soluble CD14 and other factors. So this class of drugs reduces indices of monocyte and T-cell activation, specifically among people with HIV. So you have very interesting pleiotropic effects that we thought to leverage in our trial. So REPRIEVE was just published this year, and this was conducted in 110 sites across the United States, Canada, Spain, Thailand, Brazil, South Africa, Zimbabwe, Uganda, Botswana, Peru, India, and Haiti, and here in Atlanta. There was a lot of participants in Atlanta, and thank you to many of you here who I'm sure helped us to accomplish REPRIEVE. We appreciate it very, very much. And this was quite an endeavor. It was funded by NIH as well as some pharmaceutical funding, and it was supported by the AIDS Clinical Trial Group. So the design is really straightforward. These were asymptomatic, so this is a prevention trial. Asymptomatic people with HIV on antiretroviral therapy with low to moderate ASCVD risk, because if you have a high ASCVD risk, you should go on a statin, period. And there was no equipoise. So this was putting those people aside, which we hope you would treat no matter what, and dealing with the people that you would not normally treat, who represent a large group at risk for cardiovascular disease. And we ran the trial with our primary outcome as MACE, cardiovascular death, MI, unstable angina, TIA, stroke, arterial revascularization, or peripheral artery disease. And we had a lot of secondary endpoints. We're looking at diabetes, we're looking at infections, we're looking at effects on cancer, all of which have had statin-related effects in prior studies, but none was this big. We're also looking at secondary components and predictors of statin effects, all sorts of things. Embedded in REPRIEVE was a mechanistic sub-study, which itself was 805 patients, participants, and this was done over 2 years using CT angiography to look at some of the pathophysiology, and we had really deep phenotyping for inflammation and immune activation and plaque. And we enrolled 7,769 patients in the main study. And why did we use pitavastatin in our study? Because it's minimally metabolized by CYP3A with good effects on lipids and inflammatory pathways. And the statins you could use in people with HIV include the following: Prava, Atorva, Rasuva, or Pitava. And they all have pretty good LDL lowering. Pitavastatin is excellent in that regard. It's not known to have any interactions with ART. Same with pravastatin. It has a bigger lipid-lowering effect than pravastatin, and it also is probably more anti-inflammatory than pravastatin. But as you'll see when the talk about the guidelines, you could use rosuvastatin and atorvastatin as well if pitavastatin is not available. So there was a rationale as to why we did use this drug specifically in this trial. There was no reported effect on glucose in primary trials, but I'll tell you about some effects on diabetes that we saw in our current trial. So this is a study population, age between 40 to 75. Why? Because that's who you could calculate a score on. The ASCVD risk calculator doesn't go lower than 40, and the risk in that group is probably very, very low anyway. No prior ASCVD, and then a combination of the risk score and LDL. So you could have a risk score less than 7.5 and LDL up to 190, between 7.5 and 10 with an LDL less than 160, or between 10 and 15 you could get in as long as your LDL was less than 130. So it was a hybrid score based on both LDL and the 10-year pool cohort risk equation, which you can get online, and that's really interesting to use in your patients. We didn't allow statins, gemfibrozol, or PCSK9 inhibitors, or people with decompensated cirrhosis. And by the way, it had no effect on liver function whatsoever, so, but anyway. This one I'll let you take interactive because people didn't do so well on this one, so let's take this one. Which statement is true regarding REPRIEVE? Okay, let's see what you said. Okay, so this was a hard question. So that's why, let's go over this. Okay, so the number needed to treat compares favorably with antihypertensive therapy and aspirin. That's true, so 43% got that right. The effect size was larger among those with higher baseline LDL. You'd think that would be true, wouldn't you? Boy, I would think that would be true. Absolutely not true. Absolutely not true. the result was independent of the baseline LDL, which to us suggests that there's other mechanisms. I would have thought that too. Diabetes rates were increased and the statin efficacy was lower in participants with diabetes. Half of that sentence is true, the other half is not true. Diabetes rates were increased by about 29%, which is very, very consistent with all the other studies. But the overall effect was positive, even considering diabetes, and statins were effective among people with diabetes, equally effective, if not more effective in the group with diabetes. And in fact, when you get diabetes, you're supposed to go on a statin. So to us, this was, expected, and it didn't affect the overall, it didn't, impact the overall efficacy. The effect size of 35% to reduce MACE is smaller than that seen with semaglutide and canakinumab. Well, they do have good effect sizes, but REPRIEVE effect size was larger. Semaglutide was 20% and canakinumab was 15%, and REPRIEVE was 35%. So that was a hard question, but you guys did great. So these are the main results of REPRIEVE. 35% reduction versus placebo on the left, the primary endpoint. These were published in the New England Journal last year. 35% versus placebo is a much larger effect size than we anticipated. And first MACE or death was minus 21% versus placebo. The final results of the trial are going to be published in next week. These were the preliminary sort of almost final results when the DSMB met and stopped the trial for efficacy. We then had to get people in for a final study visit. It didn't alter the results much. In fact, the final results are a little more favorable even than these results. So you'll see those coming out soon, but basically you can quote these if you like. So let's look at some of the components of MACE. The first primary MACE I already showed you was around 0.65, 0.64. Here in this analysis, we added hard MACE. Hard MACE means stroke, myocardial infarction, or death. Put aside peripheral artery disease, put aside TIA, sort of the fluffier stuff, hard endpoints. And if you look at the hard endpoints, it was 0.59, which is a strikingly effective hazard ratio. You're reducing it by 41%. If you look at the subcomponents of MACE, and you really follow the point estimates, don't regard the confidence intervals, because when you get to subgroups, you don't have enough power for the confidence. But just look at the point estimates. Let's see if I have a pointer here. That's hard to work. Anyway, if you look at the point estimates of the subcomponents, they're all very, very consistent. Peripheral artery disease is way to the left, but there was only 6 events. Couple points to make, so that's good, first of all. Second of all, there was an equal number of strokes, just about the same number of strokes as there were MIs, which was very striking to us that this young population was having strokes. And we need to do more research on strokes. But the good news is that pitavastatin, and probably most statins, will prevent strokes in this population. You can see the hazard ratio for stroke is 0.62, which is quite good. Let's talk about some key subgroups. So I want to point out that the study enrolled many women, and we're very proud of that. We're very proud that we had about 30% women or so, females. We also are very proud that there was only the non-whites were 65% in this trial, and that we were in Africa and sub-Saharan Africa. This is an incredibly diverse trial, and we had power to make statements about that in our trial. So first of all, regarding sex, there was no difference in the efficacy among men and women, and this is a great result to show. Also, there was no difference in the results by baseline LDL, which I mentioned before, one of my trick questions. So there was no difference if you were less than 130 or more than 130 baseline LDL. There was also generally consistent results across age, across most GBD regions, and there was no treatment modification based on CD4, nadir CD4, HIV, RNA, or ART duration. Notice that what I'm saying is that there was no treatment modification. Statins were equally efficacious if you had a blip of viral load or not, but the statement I made earlier was in the natural history placebo arm, it was viral load that was a contributing factor. So there are two different points. How about our effects on cholesterol? Oh, before that, 80% remained in study in both groups. This is over an average follow-up of 5 years, and this is terrific. We're so happy for this, and also very proud of our sites to help us achieve this incredible adherence in the trial. LDL was reduced by 30%, exactly what you'd predict from a moderate intensity statin, which is good. I'll show you how you might interpret that in a moment. And the results right here. There was no drift down in the placebo arm, so this is clearly a biomarker of adherence as well. And also, of course, we got thrown a major pandemic during the trial, and we navigated our way through that. But we adjudicated every event after COVID for COVID relatedness, and only one event had COVID relatedness. So this trial is independent of any effects of COVID. In terms of safety, the DSMB concluded there was no unanticipated safety concerns. Only 1% versus 0.5% withdrew for muscle-related symptoms. Diabetes rates were increased, but 5.3% versus 4% in the placebo group. So it was really only like a 1% difference. This was consistent with other studies, and the protective effect of statins was seen in this group. There was a 50% reduction in MACE among diabetics in Pitava versus placebo. There was no effect on liver function, rhabdo, or other anticipated side effects. I want to go over this really carefully. This is a nomogram by the CTTC collaborative, which plots the difference in LDL between treatment and placebo on the x-axis, and the anticipated, or the reduction in MACE on the y-axis. And you follow the line there, and these are all the different studies, and you look at REPRIEVE, which is the green dotted line, and we had a 0.8 millimole difference. That was that 30% reduction in LDL. Go up to the line and go over, and we should have seen a 17% reduction in MACE. We should have seen that. If it was totally based on LDL, that's what we should have seen. And in fact, we saw double that. We saw a 35% reduction, which says to us that there's something happening here beyond LDL reduction, which we're trying to figure out as we speak. The number needed to treat, this is like how many you need to treat to achieve your result. The overall was 100, so you need to treat 100 people to prevent a MACE event. Actually, that compares, very favorably to antihypertensives and aspirin, which are in the 200 and 300 range. And it's a really, really good number needed to treat as you go up with the baseline risk. So even people who had around 5 or between 5 and 10, it was a really small number needed to treat in the 50s. And even people with just very low predicted risks, like 2.5 to 5, it was 130, which is quite good. So these are a pretty reasonable number needed to treat, and you can think about that when you see these patients in clinic. And indeed, the American Heart Association, the ACC, and HIV, worked together to change the guidelines recently, and this is a big deal. So these are now the new AHA guidelines for the treatment and the primary prevention of cardiovascular disease. And so I'll draw your attention to the red circle there. And before, people at low risk, borderline risk, and even intermediate risk were not necessarily mandated to have a statin. There was recommendation for a discussion, but in HIV it was listed as a risk-enhancing factor, but there was no specific recommendation. It was left to the clinician. Based on the results of the REPRIEVE, the AHA now recommends that anyone with HIV over 5% be prescribed a statin, okay? It's an A1 recommendation for pitavastatin, but they were very wise, and they included an A2 option when pitavastatin was not available, because they felt there was probably likely to be a class effect. So the A2 would include Rasuva or Atorva, and that was based on the slide I showed you earlier. And what is interesting to us is they actually even gave a C1, which it sounds like a bad grade, C, but the C1 recommendation is not terrible. It's a kind of a softer recommendation, but not a non-recommendation. And they even gave a C1 for people with less than 5%. So, and you do realize that if you're 45 years old today and your score is 4.5%, next year it's going to be over 5% just based on your age alone increasing. So essentially, if you think about it, this is kind of like a global recommendation of statins for this population. And I think this will save lives. Obviously, you have to have a discussion with your patients, and I'm not trying to peddle a drug here, I don't care, but I do want to save lives. And I think, this very robust randomized trial has proved that you can save lives without much safety risk. Let's talk a little bit about the predictiveness of the score. The bottom line here is we use this AHA-ACC pool cohort risk equation, and I just want to focus on 2 points on this slide. Black or African Americans and females, okay? This risk prediction significantly underpredicted events in those two populations. The observed to expected ratio was way off in those populations, and you can see in the, you can see in the line for females and the line for Black or African Americans, the dots are way above the linear regression line. So the observed to expected is off, and that equation will underpredict in those two populations. We are in the process of going through our data, and we'll be publishing, hopefully soon, a correction factor, if you will, of how you would adapt to that. What would you multiply the score by to get the score back to, we call it calibrated. And so we'll be looking at that. But in your mind, know that the score is not working for women, and we can talk about why that may be the case in the question and answer period. We also looked at the coronary arteries, and you see here a kind of a juicy plaque where the arrow is on the coronary angiogram, CTA angiogram of the patient, and it's an eccentric, non-calcified, soft plaque. And we looked at our effects on plaque and biomarkers in the sub-study. And we just published this in JAMA Cardiology like a month ago. And here we're showing that there was a significant reduction in non-calcified plaque, our primary endpoint. Among those with plaque at baseline, there was a 12% reduction, and this is over 2 years, not the 5 years, okay? And a significant reduction in progression, a 33% reduction in progression. And you can see on the pie graphs, you can tell that there was much more progression in placebo than in Pitava, and much more regression in Pitava than placebo. We also looked at biomarkers, and some really important inflammatory biomarkers decreased. LPPLA2, oxidized LDL. There was a hint that CRP went down, but it wasn't very high to begin with in this population, which was also very interesting to us. The interesting thing is that the change in the biomarkers did not predict change in plaque. There was a suggestion that the change in LDL was modifying plaque, but the confidence intervals crossed, so it was a modest effect. So we haven't figured out what we did to modify plaque yet. We're still on the hunt for the correct biomarker that may help us predict that. Now, in that regard, we did proteomics, and these results are under review. And you can see that we saw a lot of very interesting molecules that changed significantly with pitavastatin. One of them, which was so interesting to us, was called p-Colc, which is a gene that helps to regulate collagen formation. And so that was interesting to us. And in fact, the change in p-Colc mediated 84% of the change in non-calcified plaque, and other biomarkers were not significant, which is a huge amount. And in fact, what we showed was that p-Colc actually, by increasing collagen, tended to make the plaque more fibrous and more calcified, make it harder, less soft, less vulnerable for rupture, because of the collagen that it was increasing in the wall of the plaque, which is really an interesting and very novel observation that will be hopefully published shortly. And so our basic hypothesis here is that pitavastatin, by increasing PCOLC expression, increases fibrillar collagen and cross-linking matrix with increasing deposition of calcium and make the plaque harder, if you will. And that renders it less likely to rupture. And that could be a very novel mechanism, by the way, by which statins work. And by the way, you might have heard in prior studies that the calcium score goes up when you give a statin, and it does. So don't be confused by that. We're not making the patients worse. Clearly, we're reducing the MACE, but we're changing the composition of the plaque in the coronary arteries. Other proteins change. I'm not going to have time to go over this, but just at my time here. So in summary, cardiovascular risk has increased among people with HIV despite young age and only low to moderate traditional risk. Among this population on ART with low to moderate risk and normal LDL, the baseline LDL was only 106. Treatment with a statin strategy was well tolerated and will prevent MACE at a very reasonable number needed to treat. And it's an effect greater than that explained from LDL reduction alone. And we need to do further work to understand how to utilize our PCE score to assess the clinical implications on MACE and look at this novel mechanism that we just uncovered. So thank you very much for your attention. I really appreciate it.
Thank you, Steve. That was very interesting. We have several questions. A couple people asked about the calculators like the AHA, et cetera.
Yeah.
Are they going to incorporate HIV as an independent risk factor?
Oh, they did include HIV as an independent risk factor previously, but they didn't like act on that. So they just threw it out there as a potential risk. Now then they came back with an actual recommendation to begin statin at a certain point. So they have markedly changed the guidelines. So that's still there, but now they recommend when to prescribe.
Another question is about the risk calculators is, do we know if there should be a change in the risk calculator based on trans women, trans men status? Does that change your risk?
Yeah, we have about 120 trans participants in our trial. They actually do have some novel risk factors like body composition changes, and it's probably not big enough to do a super analysis in, but we will look at that, and it's a really, really important question.
How do you respond to patients who read or hear about the fact that statins are associated with dementia? Yeah,
they're also associated with improvement in cancer. I mean, you can pick your endpoint if you want. We are going to look at that in REPRIEVE in some cross-collateralized studies. There's some anxiety if you drive the cholesterol too low, you could have cognitive problems, but that's not a problem in REPRIEVE. That's more of a problem with PCSK9, where you can get the LDL down to 10. Ours went down to 70. I would say it's probably the opposite if you ask me, but that by reducing neuroinflammation, you might actually improve cognition, but the data are mixed, so we need more randomized trials in that regard. There have been some trials looking at DHA and icosapentaenoic acid and other things, but they have a much, much more modest effect than we showed in this. So I would say it's not either or, it's both, is the way I would answer that question. And so I'll leave it at that.
And based on this trial and other trials looking at the concept of using anti-inflammatory modifiers for heart disease, is a statin the end of our road here, or do you think we're going to be combining other anti-inflammatory drugs?
So that's a really, really important question. So I think 35% is a really good reduction. There might be residual risk in certain populations, and those, we have to find the right biomarker that predicts those who have residual risk and then attack it, okay? The problem is that, this trial checked a lot of boxes: easily applicable, safe, scalable. If you're going to use an anti-IL-6 or some super fancy thing. It has to be safe, it has to be scalable, and as I mentioned, it can't reduce inflammation so much, that's the body's defense, that basically you unleash opportunistic infections, which exactly happened in canakinumab. So this is my field, but it's a very hard needle to thread. Statin is the obvious answer, and then we need to go down second and third. It's going to be, hard to find the other strategies.
Okay. Question from the audience? Go ahead.
Sure. Apologies if I missed it. This was a global trial. Is there any update on how this is affecting global guidelines?
Yes. So at CROI, I had a discussion with the WHO people who make their guidelines. In sub-Saharan Africa, they go more by WHO than they go by AHA. So I heard, she told me that they're working on it, and we didn't see as much cardiovascular disease, and I don't know if you caught on the slide, I didn't see quite as much as we might have anticipated in people in sub-Saharan Africa and also in Asia, but some of the people that were recruited in those areas were young women, a lot of very, very young women. And so even though the risk predictor is off, still women have more cardiovascular disease relative to men, but still in an absolute sense, men have more cardiovascular disease in general. So basically the bottom line is that WHO is thinking about it, and I suspect they will make guidelines, but there's no pitavastatin in sub-Saharan Africa. But there is atorvastatin, and it's cheap as hell, pennies. So, they might recommend something like that. And, I don't know whether they're going to exactly recapitulate it, but it's a super important question because people in sub-Saharan Africa, they don't really care what the AHA says. They want the WHO endorsement, and so we need to wait for that. But while we're waiting, 2/3 of the population was, in other regions, and certainly this is applicable for them.
Okay. Well, that reaches the end of our time for questions. Thank you very much,
Okay,
Dr. Grinspoon, and we'll go ahead and move on to our next speaker.
Great.